Welcome to the deep dive, your express route to becoming seriously well-informed. We basically cut through the noise.
Exactly. We take the essentials and try to make them stick.
Today, we're focusing in on something really crucial, especially if you're working with kids or, hitting the books for exams. Pediatric appendicitis.
Yes. Absolutely fundamental.
We're using our revision notes as the foundation here, and the plan is to give you a really clear, high-yield overview of this condition.
We'll cover the definition, causes, risks, how it develops.
What else it could be, who gets it, the signs, diagnosis, treatment, the whole lot.
And potential problems, of course.
Yeah. I remember just feeling totally lost trying to get my head around some of these big medical topics back in the day. So clarity is the goal, those aha moments.
Well, a solid grasp of pediatric appendicitis is vital. It's often time-critical, so understanding the basics is key for, well, good clinical practice and exam success. Let's get into it.
All right, let's start right at the beginning. In simple terms, what exactly are we talking about with appendicitis?
Okay, so appendicitis is basically inflammation of the appendix. You know that little finger-like pouch that comes off the large intestine?
Right.
When that gets inflamed, that's appendicitis. And it's actually a really common reason for children needing emergency surgery.
Okay, inflammation. But how does that start?
It usually kicks off with a sudden blockage inside the appendix, the channel inside. We call it luminal obstruction.
Like something gets stuck?
Exactly. Think of it like a tiny pipe getting clogged. And once it's blocked, the normal bacteria that live in our gut can sort of invade the appendix wall.
Ah, okay.
And that leads to the inflammation and eventually infection of the wall itself.
And I guess that's not something you want to leave alone? Sounds like it could get nasty.
Definitely not. The big worry is perforation rupture. If that inflamed appendix actually bursts, well, all that infected stuff spills out into the abdomen.
Which causes peritonitis.
Spot on. A really serious infection of the peritoneum, the lining of the abdominal cavity. Even if it doesn't fully rupture, you can get sort of delayed perforation or gangrene, which causes a more localized peritonitis.
Okay.
And sometimes the body tries to wall off the inflammation, forming what we call an appendix mass. Basically a lump of inflamed tissue, maybe with some pus.
Or an abscess.
Or a more defined collection of pus, an appendix abscess. So understanding these risks really shows why getting treatment quickly is so important.
Absolutely critical. Okay, so that blockage, what usually causes that? What are the common culprits?
That's a good question. Often the exact cause in one specific child can be a bit uncertain.
Right.
We know the usual suspects that cause that obstruction. Most often it's a little hard piece of stool, what we call a faecolith.
Okay, makes sense.
Another common one is enlarged lymphoid tissue, the immune system hubs. Sometimes they swell up, especially after maybe a viral illness, and can block the opening. And less commonly, you might get foreign objects, though that's rarer. But whatever the cause, once it's blocked, infection tends to follow, leading to that inflammation and the risk of rupture we talked about.
Got it. So are certain kids more likely to get this? Are there specific risk factors we should be aware of?
Yes, definitely. There are a few key things. Age is a big one.
Right.
While it can happen at any age, it's most common between, say, 10 and 19 years old. Teenagers.
Okay, teenagers primarily. What else?
Family history seems to play a role. If, a parent or sibling had appendicitis, the child's risk is increased.
Interesting.
Also, certain underlying medical conditions. Cystic fibrosis is the classic example often cited.
Ah, CF. Okay.
And maybe surprisingly, having had previous abdominal surgery is also considered a risk factor.
Really? Okay, so age, family history, conditions like CF, and previous surgery.
Exactly. We could maybe try and remember that with AFMS,
Yeah.
age teen, family history, medical conditions like CF, surgery, previous abdominal. Bit clunky maybe.
AFMS. No, I like it. Helps to group them. Okay, so we know what it is, why it happens, and who's more at risk. Let's dig into the how now. How does it actually develop inside the body? Can you walk us through the steps?
Sure. We can think about the pathophysiology, the process, in about 5 main stages.
Okay.
Stage 1 is that blockage formation. Whatever causes it, the faecolith, the lymphoid tissue, it blocks the appendix. This leads to pressure building up inside.
Right, like that clogged pipe idea.
Exactly. And that increased pressure starts to squash the blood vessels in the appendix wall, impairing blood flow.
Okay, step 1, blockage and pressure.
Step 2, bacterial infection. With the blockage, normal gut bacteria, which are usually harmlessly passing through, get trapped and start to multiply and invade the appendix wall. That's where the inflammation and infection really take hold.
Makes sense. What's next?
Stage 3 is the rupture risk. As that pressure keeps building and the wall gets more inflamed and damaged, it weakens. It becomes vulnerable to actually bursting or perforating.
The dangerous part.
Very much so. Which leads to stage 4, spread of infection. If it does rupture, that infected material, Pitocin bacteria, spills into the abdominal cavity. That's peritonitis, a serious, potentially life-threatening emergency.
Okay, so blockage, bacteria, rupture risk, spread.
And the crucial 5th stage, the importance of treatment. Getting medical help quickly, ideally before it ruptures, is absolutely key to preventing these really severe complications. It's like a chain reaction. Blockage, bacteria breach, rupture risk, spread risk, and hopefully treatment acting as the crucial intervention.
That domino analogy really helps visualize it. Okay, now, abdominal pain in kids. It must be tricky sometimes, right? Lots of things can cause a sore tummy. How do doctors sort out if it's appendicitis or something else?
Oh, absolutely. It's a very common symptom, and the list of possible causes, the differential diagnosis, is pretty long. We have to consider lots of things.
Like what? Can you give us some examples?
Sure, we can group them. First, think about other gastrointestinal causes. Things like a bowel obstruction, simple constipation can sometimes cause severe pain.
Really? Even constipation?
Yes, especially if it's severe. Then there's intussusception, where the bowel telescopes into itself, a strangulated hernia, gallbladder inflammation, acute cholecystitis, though less common in kids, a perforated peptic ulcer, also less common. A big mimic is mesenteric adenitis, inflamed lymph nodes in the belly, often after a virus. That can look very similar.
I bet.
Then there's Meckel's diverticulitis, Crohn's disease, sometimes diverticulitis itself, pancreatitis, erectus sheath hematoma, a bruise in the abdominal wall muscle, and, of course, this straightforward gastroenteritis, a stomach bug.
Wow, okay, that's a huge list just from the gut itself. What about other systems?
Right. Then you have urological causes. In boys, you always have to think about testicular torsion, a surgical emergency, kidney stones, renal calculi, and urinary tract infections, UTIs.
Okay, check the urine then.
Always. And thirdly, in girls, gynecological causes. Especially in adolescence, you consider ectopic pregnancy, though rare in younger ones, ovarian cyst problems, torsion, or rupture, and pelvic inflammatory disease, PID.
Right. Important consideration.
Then there's a sort of grab bag of other possible causes, things you might not immediately connect, like diabetic ketoacidosis, DKA. Sometimes pneumonia can present with abdominal pain, referred pain, porphyria, even side effects from certain immune treatments.
Gosh.
And finally, if the doctor actually feels a mass, a lump, in that lower right area, the right iliac fossa, or RIF, the differentials for that include Crohn's, maybe a colon cancer, though very rare in kids, gallbladder issues, a psoas abscess, a kidney that's sitting low, a pelvic kidney, or an ovarian cyst.
It really highlights why a careful assessment is needed. That list is enormous.
It is, which is why taking a good history and doing a thorough exam are paramount. Maybe for some GI ones we could try, in considering many gutsy problems. Intussusception, constipation, mesenteric adenitis, gastroenteritis, pancreatitis.
And considering many gutsy problems, I like it. Might help filter that long list. Okay, let's talk numbers. How common actually is appendicitis here in the UK?
Well, looking at children, the incidence is roughly 80 to 120 cases per 100,000 kids per year. It's definitely seen more in older children and teenagers compared to the little ones.
Okay.
And overall,
It's the most common reason for an acute abdomen needing emergency abdominal surgery in the UK. About 10% of the population, so 1 in 10 people, will likely get appendicitis at some point.
1 in 10. Wow.
Yeah. Most commonly between 10 and 20 years old, like we said. But it can happen anytime, and it's slightly more common in males.
Any other interesting stats?
Well, here's something that always sparks discussion. In about 10 to 20% of appendicectomies, the surgery is to remove the appendix.
Yeah.
The appendix turns out to be normal when they look at it under the microscope.
10 to 20%. That seems quite high. It does, but it reflects the diagnostic challenge. Clinicians are often weighing the risk of missing appendicitis, which could lead to rupture and serious problems, against the risk of performing surgery when the appendix is actually okay. It's a tough balancing act, and often erring on the side of caution is preferred to avoid the complications of perforation.
That makes sense. You'd rather take out a normal appendix than leave an infected one to burst.
Okay, so what are the key signs, the symptoms, the red flags that might make someone think, could this be appendicitis?
The clinical picture can vary a bit, but there are some classic features. Abdominal pain is number one.
Right.
Typically, it starts kind of vaguely around the belly button, the umbilicus. Then over a few hours, usually it shifts or migrates down to the lower right side of the abdomen. the right iliac fossa.
That movement of pain is important.
Very important. That migration is a classic sign. Often alongside the pain, kids lose their appetite, anorexia. They might feel sick, nausea, and might vomit.
Okay, pain moving, loss of appetite, feeling sick. They might also get a bit of a fever, usually low grade. And they'll typically be tender when you press on their tummy, especially in that lower right area.
But you said it's not always classic.
Exactly. That's really crucial, especially in very young children,
Yeah.
like infants or toddlers. Their symptoms can be much vaguer, maybe just irritability, poor feeding, vomiting. It can be much harder to pin down.
So what else might a doctor look for when they examine the child?
Well, often the pain gets worse with any movement. So asking the child to cough or even just bumps in the road on the way to the hospital can make it much worse.
Right.
Initially, their temperature and heart rate might be normal, but a low-grade fever often develops.
Right.
On examination, apart from that tenderness in the right lower quadrant,
Oh, yeah.
you might find guarding where the abdominal muscles automatically tense up when you try to press there,
Okay.
and rebound tenderness, where the pain is actually worse when you quickly release the pressure rather than when you press down.
Mm.
That suggests peritoneal irritation. And there's Rovsing's sign too. Pressing on the left lower abdomen causes pain on the right side, again suggesting irritation over there.
Interesting.
And we always need to remember, presentations can be different in specific groups, like pregnant women, babies, and the elderly, though we're focused on kids today.
Right.
And clinicians often use scoring systems. You might hear about the Alvarado score or the ARR score, appendicitis inflammatory response score. These combine various signs, symptoms, and maybe basic lab results to estimate the probability of appendicitis.
Like a checklist.
Sort of, yeah.
Oh.
To help guide decision-making. Maybe think of the classic triad as MAP, migration of pain, anorexia, loss of appetite, and pyrexia fever.
MAP, migration, appetite, pyrexia. Nice one. Okay, so a good history and careful exam are key. But what about tests? What investigations help confirm things?
You're right, the diagnosis is largely clinical. But investigations are definitely helpful, especially when the picture isn't completely clear.
So what sort of tests? Blood tests.
Yeah, usually start with basics. Urinalysis is important to rule out a UTI, which can sometimes cause similar pain.
Makes sense.
And in any postmenarchal female, a pregnancy test is absolutely essential to exclude an ectopic pregnancy.
Crucial.
Then yes, blood tests, a full blood count, FBC. Often, this shows a mild rise in the white blood cell count leukocytosis, which suggests infection or inflammation.
But not always.
No, definitely not. You can absolutely have appendicitis with a normal white cell count, so it doesn't rule it out.
Okay. Anything else in bloods?
We might check inflammatory markers like CRPC reactive protein. That might be raised too. But again, a normal CRP doesn't exclude appendicitis either. They're helpful pieces of the puzzle, but not definitive on their own.
Right. What about imaging? Scans?
Imaging is often very useful when there's diagnostic uncertainty. In children and also young people and pregnant patients, ultrasound is often the first choice.
Why ultrasound first?
Mainly because it doesn't use ionizing radiation, which is always a consideration, especially in kids. It's also pretty good for looking at other things in that area, like gynecological causes of pain.
But is there a downside?
The main limitation is that it can be quite difficult to confidently see a normal appendix on ultrasound, and its accuracy can depend a lot on the operator and the child's body habitus.
Okay. So if ultrasound isn't clear,
Then CT scanning often comes next.
Hmm.
CT is generally more sensitive and specific, better at correctly identifying appendicitis.
but the radiation concern again.
Exactly. Especially in children and younger adults, we're mindful of cumulative radiation dose. Sometimes a low-dose CT protocol can be used, which tries to balance diagnostic accuracy with lower radiation.
Okay. Any other imaging?
MRI is sometimes used, but it's typically reserved for pregnant women if the ultrasound hasn't given a clear answer.
Right.
And very occasionally, if all the tests are still inconclusive, but suspicion remains high, a diagnostic laparoscopy might be considered. That's keyhole surgery, just to take a direct look.
So putting a camera in.
Yes. But really, the main takeaway is that clinical assessment drives the diagnosis, and investigations are used strategically to help confirm or clarify, especially in those uncertain cases. Think ultrasound first in kids usually, CT if needed for more certainty.
Got it. Clinical judgment first, tests to support. Okay, so let's say appendicitis is strongly suspected or confirmed. What's the plan then? What happens next?
Right. If appendicitis is suspected, the child needs to be admitted to the hospital for proper evaluation and management.
Okay. And treatment is usually surgery.
Traditionally, yes. Surgical removal of the appendix in appendicectomy has long been the gold standard, and nowadays that's very often done laparoscopically, using keyhole surgery.
Less invasive.
Yes, generally leads to quicker recovery, shorter hospital stay. However, there's been a shift, or at least more discussion, recently
Oh, about what?
about non-operative management, using just antibiotics instead of surgery. Guidelines from around 2020 suggest this might be an option for some carefully selected patients with uncomplicated appendicitis.
Just antibiotics. How well does that work?
Well, that's the debate. Studies show it can work for some, but there's a significant risk of recurrence, the appendicitis coming back later. Some studies suggest recurrence rates up to nearly 40% within 5 years.
Wow, that's quite high.
It is. And antibiotic treatment alone is generally seen as less effective overall than surgery, and often leads to more readmissions to hospital down the line.
So surgery is still the main approach?
For most cases, yes, especially if there's any sign of complication. If the diagnosis is really unclear, sometimes a period of active observation is used, keeping the child in hospital, monitoring closely, repeating exams, maybe blood tests to see how things evolve.
Okay. And what about general care?
Oh, absolutely vital. Supportive care is key. That means intravenous fluids, IV fluids to keep them hydrated, especially if they've been vomiting or not drinking, and good pain relief, analgesia.
And antibiotics, even if they have surgery.
Yes. We usually give antibiotics before the operation, preoperatively, to reduce the risk of wound infections. And if the appendix was perforated or gangrenous complicated appendicitis, then they'll need a longer course of antibiotics after the surgery too.
Okay. And you mentioned laparoscopic is preferred.
Generally, yes. The evidence tends to support the laparoscopic approach over traditional open surgery, mainly due to shorter hospital stays and faster recovery, less postoperative pain.
Makes sense.
But ultimately, the decision about surgery versus antibiotics or laparoscopic versus open needs to involve shared decision-making between the clinical team, the child, if old enough, and the parents, weighing up all the pros and cons for their specific situation.
That seems really important, the shared decision-making. Okay, so assuming treatment happens promptly, what's the outlook? What's the prognosis like for kids with appendicitis?
Generally, it's very good. If it's diagnosed quickly and treated appropriately, most children make a full and uncomplicated recovery.
That's reassuring.
It is. The problems arise, as we've touched on, if there's a delay in diagnosis or if complications develop. That can definitely worsen the outlook, lead to more significant illness, longer hospital stays, and potentially longer-term issues.
And the surgery itself is generally safe.
Appendicectomy is considered a relatively safe operation, yes. Looking at mortality rates, for non-perforated appendicitis, the risk is very low. Even with perforation, while the risk increases, it's still relatively low in the pediatric population.
Okay.
The risks are unfortunately higher in much older patients, say over 70, often because the disease progresses faster, diagnosis might be delayed, and they often have other health problems, comorbidities. But for kids, with timely care, the prognosis is usually excellent.
Good to know. But things can still go wrong. What are the potential complications we need to be aware of if things aren't caught early or treatment isn't smooth?
Absolutely. Complications can happen. The big one we keep mentioning is perforation. It occurs in maybe 60 to 30% of cases overall, and it's more common at the extremes of age, the very young and the elderly.
Okay, perforation is top of the list. What else?
Wound infection can occur after surgery. The rates vary, less than 5% maybe for simple appendicitis, but it can be up to 20% if the appendix had perforated. Giving antibiotics helps reduce this risk.
Right.
Sometimes, as we mentioned earlier, the body walls off the infection, forming an appendix mass. This might present as a fever and a palpable lump. It's often managed conservatively first with antibiotics, but might need surgery later.
And the abscess?
Yes, an appendix abscess, a collection of pus, that's usually picked up on ultrasound or CT scan. Treatment typically involves draining the pus, often using image guidance, and giving antibiotics. Sometimes an appendicectomy is done later, sometimes not.
Okay. Any other potential issues?
Less commonly, you can get other abscesses, like a pelvic abscess or even one under the diaphragm, a subphrenic abscess.
Yeah.
Temporary paralysis of the bowel, paralytic ileus, can happen after surgery. And rarely, serious blood infection, septicemia.
Septicemia, wow.
And looking long-term, very rarely, adhesions, scar tissue inside the abdomen, can form after surgery and potentially cause bowel obstruction years later.
And you mentioned pregnancy briefly earlier.
Yes, just worth noting, appendicitis in pregnancy is uncommon, but if it occurs, especially if it perforates late in pregnancy, it carries risks for both mother and baby, though maternal mortality is low overall. Fetal loss rates are higher if perforation occurs.
Right. Lots of potential pitfalls then. Maybe we can use those P's again. Perforation, pus, abscess mass, paralysis, ileus, post-op wound problems.
Yeah, something like that works. Perforation, pus, paralysis, problems, wound sepsis covers the main ones.
Okay, great. So let's try and quickly wrap up the key points from this deep dive on pediatric appendicitis. It's inflammation of that little appendix pouch, usually kicked off by a blockage. Main risk factors seem to be teenage years, having family members who've had it, and certain conditions like CF. Maybe our AFMS mnemonic helps there. Age, family history, medical conditions, surgery history.
Good recap.
Classic symptoms are that moving pain, starting central, then going to the lower right, loss of appetite, maybe fever, our MAP mnemonic, migration, appetite, pyrexia. But remember, it's not always classic, especially in little ones.
Crucial point.
Diagnosis is mostly clinical, based on listening and examining carefully, but tests like bloods and especially ultrasound or sometimes CT help confirm when needed.
Right. Supportive tests.
Treatment is usually surgery, often keyhole, to remove the appendix. Antibiotics alone are an option sometimes, but surgery is still generally the main route.
Correct. With shared decision-making.
And the outlook is generally really good if it's caught and treated early. Delays, though, can lead to serious complications like perforation, abscesses, those pee problems.
You've summarized it perfectly. The key messages are really about recognizing the possibility, assessing carefully, and acting promptly. But also, reassuringly, the advancements in diagnosis and minimally invasive surgery have really improved outcomes.
Absolutely. And if you listening want to cement this knowledge or revise further, particularly for the MSRA, do check out passmsra.com and also freemsra.com. Loads of great resources there.
Very worth a look.
So a final thought to leave you mulling over. With this evolving landscape, especially around non-operative management, what do you think will be the biggest factor driving that choice between surgery and antibiotics for uncomplicated appendicitis in kids over the next few years? Patient preference. Better imaging, fear of recurrence, something to ponder.
An interesting question indeed. Lots to consider.
Thanks for joining us for this deep dive.